Thank you so much for joining us today for the e-forum on CASLPO's new practice standards for speech-language pathology intervention. My name is Dana Prucci, and I'm the Director of Professional Practice and Quality Assurance. I'm a speech-language pathologist who worked with children, both in public and private practice. With me today is Caitlin Reed.
Thank you again to everybody for attending today. I'm Caitlin Reed, and I'm the SLP Advisor in Professional Practice and Quality Assurance at CASLPO. I'm also an SLP by background, and my clinical experience is with adults with acquired communication disorders and dysphagia.
Behind the scenes today, we have Cassandra Kaminskis. Cassandra is the CASLPO Manager of Mentorship and Audiology Practice Advisor. Cassandra will be monitoring the questions.
Before we get into the content of the presentation, we just have a couple of housekeeping items for using GoToWebinar. It's best to close other running applications to help maintain a stable connection to the platform. If you experience any technical issues, exit GoToWebinar and return into the session, which you can do at any time. This e-forum is being recorded, and we will post both the slides and video to CASLPO's website within the next couple of weeks. While the GoToWebinar appointment is from 12 until 1:30, we appreciate that everyone is busy, and we're aiming to end by 1:15 today. We're very happy to have just under 700 people attending today's session. All participants are muted, but you can ask questions at any time by typing into the question box. A minor request: it's easier for us to view if you include your whole question in the body of one message. We'll take questions during the presentation, but if you submit a question we don't get to and it isn't answered in the content of the webinar, we'll do our best to follow up with an email response within the next few weeks. If the question in the question periods today, we'll try and pick more general questions that will benefit everyone. If your question is about a specific situation, it may be better to email practice advice directly at slppracticeadvice@caslpo.com rather than submitting it here, and an advisor will be able to provide you with an individual response.
Here's today's agenda. We'll start by talking about the background and rationale for the new standards. We'll go over the guiding principles and definitions, as well as the 6 overarching or continuous standards, and we'll have our first short break for questions. Next, we'll describe the 9 intervention standards, standards 7 through 15. When we talk about the standards, we'll go through them with 2 patients, Mr. Singh and Davy. Note that these are compilations of patients. You may not agree with all the steps taken, but they are for example purposes only. Finally, we'll look at the Dysphagia Appendix. Then we'll use the rest of the time for questions. So, why did CASLPO create one set of SLP standards? In 1994, when CASLPO started, the practice standards were more fulsome. They were a little bit how-to, and there were references to research. Standards and practice guidelines were very detailed for some areas of practice. However, CASLPO was separating from the association, so the professions had to start somewhere. It made sense at the time. Ideally, a good organization would grow and change. And these practice standards and guidelines contain both must statements or standards, but also should statements. In 2018, CASLPO asked for feedback and sent a survey to all registrants asking about these practice standards and preferred practice guidelines. And the college was told standards were too long. In the last 6 to 7 years, CASLPO decided the guidelines, or should statements, were confusing for registrants. Do they have to do it, or is it best practice? And so a wise decision was made to take out the guidelines. CASLPO was also told that standards were too repetitive. Since that time, general standards like infection prevention and control and evidence-based practice have been hived off as standalone standards instead of being included in all the specific intervention standards. Note that documentation and consent are high risk. Even though they have standalone documents, they are kept in for intervention-based standards as well. Let's review exactly what standards of practice are. Practice standards are the bar that all registrants need to meet. Practice standards need to be attainable, realistic, current, relevant, nimble, and apply to all circumstances and practices across Ontario, as they're based on principles of practice. These standards are based on Ontario laws and regulations, but also evidence from research, practice trends, and changes over time. Practice standards are like the bar shown here. All registrants must at least meet the standards of practice and meet that bar. It's concerning if the registrant is practicing below the bar. That is the misconduct area. It's great to practice above the standards, but the requirement is meeting the practice standard. Why did CASLPO combine the SLP standards into one? In 2022, Sarah, one of the SLP practice advisors, was drafting the revised dysphagia standards. As a template, she used the newly revised audiological assessment standards. And she had a big aha moment. Sarah discovered a significant overlap of common standards from the audiological assessment standards that were important for dysphagia. And if you think about it, the two areas of practice are as dissimilar as our two professions can be. If the standards were the same for audiological assessments and dysphagia, what about across all areas of SLP practice? With the approach of high-level principles following the survey and zooming out on all of the SLP-specific standards, there's a significant overlap of common standards. Determination of approach, consent, virtual care, further intervention. You need to meet these standards whether as an SLP you are assessing swallowing, providing treatment to a patient with a brain injury, or education to a child and their family about stuttering. Even the competencies often crossed over. We can take a standard from the previous dysphagia standards to illustrate this concept. The standard says, SLPs must recommend an effective dysphagia plan of care that addresses the patient's concerns while minimizing patient risk. But look what happens when we take out the word dysphagia. SLPs must recommend an effective plan of care that addresses the patient's concerns while minimizing patient risk. This standard now applies to all SLP practice across Ontario, as do the competencies. We looked at all the standards related to intervention of specific disorders and assessments and consolidated them into one. Most of these standards haven't been revised in many years. There have been changes in practice since they were written. We were careful not to lose anything that was important. No musts were removed from the original standards, and nothing was lost. We removed redundancy, and we removed prescriptive statements as well as should statements, and we compared everything to the entry to practice competencies. We wanted to use an appendix when risk of harm is higher and when specific standards are required. We were intentional in our approach to ensure that all SLPs are adequately represented in these standards. We follow a rigorous, formal process for revising standards following the steps here. First, the Practice Matters Committee approved the idea of creating speech-language pathology intervention standards in 2022. CASLPO staff went through the stage of research, consultation with other colleges, and drafting the standards. We had fantastic speech-language pathologists who were part of two advisory working groups, pediatric and adult, in all different practice areas across Ontario. They looked at the draft standards from their perspectives, their regional area, and their practices. And we asked them questions, including, does the standard represent current SLP practice? Is it reasonable to say it would be professional misconduct if an SLP didn't meet this standard or failed to provide a rationale for not meeting the standard? Does the standard address risk of harm? And does the standard clearly explain the minimal performance expectation of an SLP? There were helpful discussions where the SLPs provided insight into their workplaces and regions specifically, as well as a broad view on what is achievable in other areas. The Practice Matters Committee approved the next draft for the survey consultation. 71 survey responses were received during the consultation period. This was your opportunity. Registrants and members of the public and other colleges could give feedback. We received interesting responses that guided the changes and provided questions and situations for this e-forum. We asked for additional examples of how the standards could apply to specific populations or workplaces. We wish we could put them all in. SLPs do amazing work in different roles. We may not have an example that fits what you do exactly, but the standards are broad enough to apply. The revised standards went back to the Practice Matters Committee and then the Board of Directors for final approval on September 19, 2025. They were published to the CASLPO website in French and English. Today, we have the e-forum. Next steps are creating a frequently asked question document and a document for the public. By combining the standards, registrants' burden of familiarity with all the standards is changed. There's less for registrants to keep up to date with. These standards are the principles for all areas of practice. This new set of standards is one document of 22 pages instead of 5 documents for 110 pages. The standards are written for practice in Ontario. Here we don't have the option for specializing. The document has been framed so that competencies are the same. The new SLP standards for intervention replace these 5 previous documents, which are no longer available on the CASLPO website. So this is how the standards are now organized. We'll spend the rest of the presentation going through each of the standards and their potential application. There are 6 overarching standards, including consent, risk of harm, and patient autonomy. There are 9 intervention standards, including screening, assessment, discharge, and further intervention. And these first 15 apply to everyone. The appendix is the first 15 plus standards for dysphagia. We assumed that there would be several appendices, but we found they weren't needed. The first 15 standards cover them. For example, we thought we'd need a stuttering appendix to deal with the important concept of generalization. But generalization is essential for all areas of practice. Patients need to generalize what they learn in therapy to outside of the treatment room, whether it is how to produce or using AAC to communicate with new people. Everything is covered by the previous 15 standards. Generalization, for example, is covered in Standard 7 on determination of approach and in Standard 12 on treatment. CASLPO is often approached to create new standards for specific therapy or populations, but the standards should apply to all areas of practice. Treatment approaches change. I know that therapy for autism and stuttering are very different from how they were 5 years ago. Standards need to stand the test of time. As soon as we get into clinical specificity, we're outside the realm of a regulatory standard and bleeding into best practice, which is your job as a professional, and the association's area. Again, think about the minimum bar and the principles of meeting standards. At the draft shared for the survey, there was an appendix on acquired communication disorders. Based on survey feedback, the standard in that appendix on reintegration was added to the main list of standards under discharge and further intervention as Standard 15. Standards are competency-based, focus on risk of harm, and allow for flexibility for self-regulated professionals to determine what is appropriate for their individual patients. You can see that they're more of a framework and not a how-to guide on how to practice as an SLP.
So now that we've given you an overview of how regulatory standards are created or revised, let's look at the different sections of the new SLP Intervention Standards document, starting with the guiding principles and overarching standards. As always, the guiding principles section of the SLP Intervention Standards gives an overview of the document and refers to other acts, regulations, bylaws, and standards of practice that are always to be applied in conjunction with these standards, such as the Code of Ethics. The guiding principles elaborate on the expectation that SLPs use their professional judgment in considering the patient population, area of practice, service delivery models, practice settings, available resources, and patient risk of harm based on these variables. SLPs are expected to have the necessary competencies to provide safe and adequate care in any area of practice included in their scope. There are 9 terms that are defined in the standards based on input from the advisory working group and consultation feedback. We've highlighted 4 here, but please refer to the standards for the full list. The standard defines competency as the knowledge, skill, and judgment required by an SLP to meet a standard of practice. Reasonable is defined as what a typical SLP would do in similar circumstances, applying expected care, knowledge, skill, and judgment, and this can serve as a comparative standard. Risk of harm exists when a modifiable behavior may result in a specific identifiable adverse event that's likely to impact a patient's physical, social, medical, psychological, and/or financial well-being. And lastly, a standard is the minimum performance level required by an SLP to provide safe, quality services and care to patients.
Let's get started with our first poll. This poll comes from the survey. Thank you to the SLP who suggested it. Who does CASLPO hold responsible for being familiar with the acts, like the Regulated Health Professions Act, the Personal Health Information Protection Act, and Healthcare Consent Act? The answers could be you, your workplace, your colleagues, such as a professional practice lead, or your direct leader. Thank you so much to everybody who has taken part in the poll. We can close the poll and share the results. So happily, everybody said you, the speech pathologist, and then we have some votes for your workplace, your colleagues, and your direct leader. So let's look at what we thought. The answer is you, the CASLPO registrant. On the survey, the SLP asked for a statement in the standard to say, quote, the expectation is of some level of familiarity with key legislative documents like Personal Health Information Protection Act and the Healthcare Consent Act, in addition to the reference to the consent and capacity standards. Many clinicians don't know the basics well and rely on their supervisors and organization to put in measures to ensure they are compliant. We took this comment, but didn't make any changes to the document. These are CASLPO expectations. This is a friendly reminder that even if your workplace takes care of meeting legislation, it's still your responsibility to know them. It's great if your workplace has forms and processes ready for you. Some workplaces have professional practice leads who ensure all SLPs are meeting the processes and therefore standards. However, it's your job as a self-regulated health professional. Consider billing or advertising in private practice. Even if you're not the one that runs the website, you are responsible to ensure there are no testimonials and the website meets CASLPO's advertising standard. This may seem like an obvious question and answer, but it bears mentioning. It came up in the survey, and we see questions in practice advice where registrants should be more familiar with the acts and legislation. CASLPO does not expect registrants to know the acts inside out, but be aware of them and know how to apply them to your practice. When you have questions, we encourage you to contact practice advice.
The next section of the document is the overarching standards, which are standards 1 through 6. So during the remainder of the e-forum, we'll go through 2 hypothetical cases to demonstrate how the standards might be applied in practice. These aren't real patients. While respecting that all patients are different, Dana and I have tried to construct fairly common presentations that SLPs might see in practice to demonstrate a broad application of the standards.
With my pediatric background, I'll present on Davey. His parents and staff at the Early On Center are worried that while he's talking, he's really hard to understand.
And our adult patient, who we've called Mr. Singh, has been admitted to the hospital after a left middle cerebral artery stroke. Again, we tried to think about a typical patient in a hospital setting with swallowing difficulties and possible aphasia post-stroke. As we go through the standards today, we'll talk about details of their cases and refer to the applicable standards. So before we discuss our hypothetical patients, please note that these situations are strictly intended to illustrate how the standards might be applied in practice. It should not be construed as clinical guidance, and you may make other decisions or have different resources based on your practice setting than what are discussed here. It would have been impossible for us to include enough polls and examples for this e-forum to reflect the breadth of practice for all SLPs in the province. However, these standards apply to everyone. Even if the poll asks about a different area of practice than your own, we encourage you to respond to the polls with the principles in mind. The overarching standards will apply continuously throughout the intervention, not just at one point in time. The first standard is that SLP's intervention must acknowledge patient autonomy. Patient autonomy is a fundamental principle of ethical healthcare, where healthcare professionals recognize a competent patient's right to make decisions about their own care, including refusing proposed interventions. Respecting patient autonomy is the first principle in the Code of Ethics, and the advisory working group and registrants who responded to the public consultation survey felt that patient autonomy is so important that it warranted being included in these standards as well. So we won't spend a lot of time on the next two standards on consent and documentation, since CASLPO recently held an e-forum to review these two revised independent standards. Again, as with patient autonomy, it cannot be overstated how fundamental these two concepts are to ethical healthcare practice. As such, they're reflected in individual documents and are included as overarching standards in the new SLP Intervention Standards. So while we're not going to cover the documentation standard in depth, we would be remiss not to address the concept of a reasonable time to complete documentation. It's important to reiterate here that regulatory practice standards are principle-based as opposed to specific or prescriptive, and must apply to and be attainable for all registrants in all practice settings, geographic locations, and workplaces across the province. That is why the standards use the phrase reasonable time. It's not possible for CASLPO to define or set this explicitly, as it will depend on multiple factors and would also take away registrants' ability to exercise their independent professional judgment on what is appropriate or reasonable for their individual patients, which is a central principle of professional self-regulation. It's important to note that you may also be subject to additional requirements dictated by your workplace that go beyond CASLPO's minimum standards. Workplaces can determine additional expectations through policies or procedures. For example, set a specific time frame for documentation to be completed based on factors such as the service delivery model or patient population. We often give the example in practice advice that what might be reasonable for timely documentation in a school board setting would likely not translate to acute care. So now we'll return to our hypothetical patients for what an application of these first standards might look like in practice.
Throughout intervention, the SLP would speak with Davy's substitute decision maker, which in this case are his parents. Davy's SDMs could accept assessment, treatment, and the goals, or decline them, even if the SLP doesn't agree. And this all fits in to Standard 1 on patient autonomy. The SLP would obtain and document both informed and knowledgeable consent at every step of intervention. Standard 2, consent. At all stages of intervention, the SLP would document clinical conversations and what happens at the sessions. And this would be Standard 3 on documentation.
So with Mr. Singh, in this scenario, the SLP has received a referral from the physician to assess the patient swallowing post-stroke, as he's been coughing when drinking. When the SLP introduces themselves and explains who they are and why they've been asked to see him, Mr. Singh states that he's not interested in having his swallow assessed. Mr. Singh's daughter is very involved in his care and wants the SLP to proceed with the assessment. Meeting the patient autonomy standard would mean ensuring that he has all the information to make an informed decision and to respect that decision. After determining that Mr. Singh is able to understand the information and appreciate the consequences of his decision, the SLP deems that he has capacity to withhold consent for the swallowing assessment. This aligns with Standard 2, consent. Capacity evaluations were covered in more detail in the December e-forum on the revised consent and capacity standards, so we won't go into detail here. The SLP documents all of the information shared during the consent discussion, for example, the risk of developing aspiration pneumonia, and the patient's ultimate decision to decline the assessment. This meets both Standard 2 consent and Standard 3 documentation. The SLP also documents the relevant details from their discussions with the patient, daughter, and interdisciplinary team members, which again aligns with Standard 3 documentation.
Standard 4 says that speech-language pathologists must identify real or potential risk of harm associated with intervention and take reasonable steps to mitigate any risks. These could be risk of physical discomfort or harm, risk of emotional or psychological harm, or risk of harm to patients' communication and swallowing outcomes. For example, you might think of the benefits of not immediately starting intervention after a brain injury or for an early stutter. Standard 5 is SLPs must have or make reasonable attempts to obtain the resources required to provide safe and appropriate patient-centered intervention. Resources include the equipment, physical environment, and technology. This standard also relates to Standard 11 on recommendations and collaboration. When there are limitations or risks with the environment and other resources, you need to refer to other professionals. Standard 6 says SLPs must ensure that virtual care is in the patient's best interest and that it is feasible, appropriate, and reliable. And this adheres to the virtual care standards. This standard does not include virtual care in dysphagia, which is covered in the appendix. While mitigating risk of harm includes determining best time for intervention, that might be out of the SLP's ability, depending on workplace. For example, in the preschool speech and language program, there could be long wait lists before Davy would be seen for his assessment. The SLP must communicate risks and potential impact to Davy's parents, and this falls under Standard 4 risk of harm. The SLP will choose appropriate tools for the intervention sessions. The SLP must maintain competency and remain knowledgeable on current evidence-informed practices. Intervention approaches change. As regulated health professionals, we take part in annual continuous learning to remain competent. And this would be Standard 5 resources. Will there be virtual treatment? If needed or appropriate. For Davy, the assessment was virtual. This would be Standard 6 and virtual care.
So in our second patient scenario, now consider if Mr. Singh develops a worsening cough and fever, and the most responsible provider, or MRP, sends a new referral for a swallowing assessment to rule out aspiration pneumonia. While respecting his autonomy, the SLP explains this development to Mr. Singh and reiterates the information that was provided earlier regarding aspiration pneumonia and the rationale for assessment to accurately evaluate whether a swallowing impairment is contributing to his current health, and if so, to determine appropriate management strategies to minimize risks associated with aspiration. This aligns with the risk management standard. Mr. Singh now provides informed consent for the swallowing assessment, which goes back to Standard 2 consent. Instrumental assessment, either video fluoroscopy or fiber optic endoscopic evaluation of swallowing, is not available at this site, so the SLP determines to proceed with a clinical swallowing assessment and explains their rationale and the limitations of a clinical assessment to Mr. Singh. For example, that it does not allow for a definitive assessment of the pharyngeal phase of swallowing. Based on the nature of the referral, it would have been preferable to definitively rule out aspiration with an instrumental assessment. However, the standards only require that SLPs make reasonable attempts to obtain resources. We did have feedback on the public consultation survey on how to interpret taking reasonable steps, and we would say that it's not an expectation to take measures that aren't possible. So for example, to use equipment that your facility doesn't have. In a hospital setting, ensuring that the SLP knows and adheres to all routine and transmission-based, like contact or droplet, infection prevention and control practices would also demonstrate meeting the resource standard. And again, note that virtual care was not discussed here because there's a specific standard regarding virtual care in dysphagia intervention in the appendix, which we'll review in the later slides. So for our second poll, what could reasonable efforts be in instances where the risk of harm cannot be mitigated? So for example, a patient's swallow is not safe with any fluid consistency or diet texture, but the patient wishes to pursue eating a regular diet at risk. So the options are A, adequately discuss all the potential risks, side effects, and consequences of eating at risk. B, answer any questions that the patient or the relevant others have. C, discourage the patient from pursuing eating at risk. D, discuss with a physician and order a pureed diet and moderately thick fluids. Or E, commit to following up with the patient in an agreed upon time frame. And again, you can choose all the options that apply.
We'll close the poll.
Okay, thank you to everybody who responded to the poll. It looks like options A, B, and E were most popular, but we did have a few people respond to C and D. So if we go back to our slides, in this poll, the bolded answers would be what we would consider reasonable efforts. We would disagree with option C and D, as those would likely not be respecting patient autonomy and or consent. So that brings us to our first question period. If you have any questions from the first few sections of the presentation, please feel free to type them in the question box now or at any time. While Cassandra and Dana are reviewing the questions that are coming in so far, we did think that it would be helpful to share this question that we received in advance of today. So somebody submitted earlier, why didn't you retain the research-based information from the acquired cognitive communication standards? We thought that that was helpful to reiterate that regulatory standards are principle-based and not prescriptive. So grounding standards in current evidence as opposed to principles creates difficulty in maintaining standards that remain relevant. It would also not be aligned with CASLPO's regulatory mandate to keep registrants apprised of current evidence-informed practices or research. That is the responsibility of individual SLPs as self-regulated healthcare professionals. As Dana mentioned earlier, professional associations and your professional networks are great resources for staying on top of current research.
Okay. So one question we seem to be getting pretty commonly, is it possible to still access previous practice standards that were previously available on the website? For example, the dysphagia and stuttering standards. Dana or Caitlin, could I turn that over to you?
Sure thing. We don't have them up on the website anymore because everything, all of the musts, if you think about this again from a regulatory point of view, they're all included in the new SLP Intervention Standards. There's nothing, as I said before, nothing was lost. If you would really like to have a look at them, you can reach out to us and we can send them to you. But the focus now is on the new standards because we're talking about regulation, and it's not about the best way to do it. It's not about how to work in fluency, but really, what are those standards that you need to meet?
I do see we have one more question that we can address here before we continue with the presentation. Someone asked, what do you do when a teen under the age of 18 refuses consent, but parents want SLP intervention? This is a good question that goes back to capacity. The capacity is defined in the Healthcare Consent Act, and there's no specific age of consent in Ontario. It really is based on your evaluation as the healthcare provider for what you're proposing. It's up to you to evaluate whether the person can understand the information and appreciate the consequences of their decision. So if it's somebody, regardless of age, that you think has capacity to make the decision, you would get informed consent from them. And again, we have a lot of resources on the website for this topic specifically and in the consent and capacity standards.
I see one more question. Maybe this will be our last question for this time, and we'll go back. We'll take more questions at the last one. How can we approach treatment when there are separated parents with different choices for intervention? So we did talk about this at the Consent and Capacity Standards and Documentation Standards e-forum a few months ago, and where parents are separated and have different plans for intervention. And since we talked about it there, and for simplicity's sake, we haven't added that to Davy's scenario. In reality, this is something that comes up for speech pathologists where substitute decision makers disagree on intervention. Consent for intervention and patient autonomy are essential in healthcare. So it's important for you as the SLP to determine if one person has higher authority than the other. But overall, intervention cannot proceed without appropriate consent. As far as custody, we have a great practice advice article, frequently asked questions, as well as other resources on custody and consent available. Okay, let's move on with the rest of the presentation, and we can come back to more questions at the end. The intervention standards, standards 7 through 15, are written chronologically for the process that a patient goes through, like screening, if it happens, then assessment, then treatment or consultation. However, in reality, some of these steps aren't linear. For example, education happens throughout intervention, after the assessment, during treatment, and at discharge. Standard 7 says, speech-language pathologists must recommend a patient-centered plan of care that addresses the patient's concerns while minimizing patient risk. Competencies include developing an evidence-informed intervention plan, applying clinical reasoning to guide the intervention in response to the patient's needs, delivering patient-centered intervention, collaborating as necessary to maintain a positive therapeutic relationship, and incorporating generalization of skills and goals into the plan of care. Standard 8 says that SLPs must review relevant background information and obtain a case history to determine a patient's intervention needs. A case history is needed in determining the intervention plan to know if certain steps may be contraindicated. Competencies include collecting and analyzing personal health information in partnership with the patient and others, recognizing conditions that pose a risk, contraindicate intervention, or require alternative recommendations or referrals, and determining when and if intervention can safely proceed. Standard 9 is SLPs must only use screenings for the purpose of identifying the need for an assessment, not for treatment planning. And again, not everyone has a screening. Standard 7 can be as simple as choosing developmentally appropriate toys and using appropriate tools with Davy. Standard 7 and developing a patient-centered plan of care means addressing the patient or their relevant others' concerns, the patient's willingness, reason for referral, patient's identities, any possible trauma, and their environment. Use strategies that are respectful to each unique patient. Davy was referred by the Early On program. His parents describe him as busy and sensitive to loud noises. These are part of case history and Standard 8. Davy has a screening, which could be done by an SLP or anyone trained like support personnel or teachers. Standard 9 on screening says that screening gets a pass or fail or refer result. Fail or refer when there are concerns. Davy's goals were not set at the screening. For Davy, the screening revealed concerns. The decision was to refer for an SLP assessment, agreed to by his parents.
So for Mr. Singh, as part of the SLP swallowing assessment, they conduct a comprehensive case history that includes a chart review of relevant information. For dysphagia, that could be respiratory history, gastrointestinal history, and neurological history, for example, which aligns with Standard 8 case history. The SLP also completes a clinical interview with both Mr. Singh and his daughter to gather information on his swallowing symptoms, as well as his food preferences and his goals for the assessment, if any. This demonstrates meeting Standard 7, patient-centered care. During the clinical interview, the SLP also notes some issues with word finding and obtains consent to complete a brief language screening to identify the need for an assessment, which shows how Standard 9 screening might be applied here.
Standard 10 says speech-language pathologists must perform an assessment that provides adequate information to develop appropriate treatment recommendations. At the assessment, you would determine a patient's communication or swallowing status, resulting in one or more specific treatment recommendations. These are the foundation for the treatment plan. Time for our next poll. What must an assessment of a school-age child include? Please choose all that apply. Maybe it depends on the child's developmental level, maybe a standardized test battery with no deviation, a language sample, the assessment tools dictated by your workplace, or augmentative and alternative communication trial. Votes are still coming in, but I think we'll have to close it and take up we'll see what everybody said. So lots of people, 95% of you, thought that it would depend on the child's developmental level. Half of you said a language sample, 9% said standardized test batteries, 17% said do what your workplace says, and 3% said AAC trial. I'm going to guess that those 3% are people that work in AAC. Let's see the answers that we came up with. So we thought that A is the best answer, but C and E are also possible. But I do think that we can agree that it's not B or D, because in B, it's important to remember that that SLP practice requires clinical reasoning. So you can use non-standardized testing or use standardized tests in a non-standardized way, knowing that you need to have a clinical rationale. And that is something that you could put in the documentation. It's also not D, because you need to use your professional judgment. The Code of Ethics, Principle 3, Accountability, paragraph D says that SLPs need to exercise independent professional judgment throughout the provision of any professional services. So it's up to you as the clinician on what to do for the assessment. It's not something that your workplace can say to you. It's important to remember that in this question, there are no regulatory musts for assessing children. Decisions are made based on your professional judgment. Going back to Davy, the assessment started virtually. The SLP spoke with the parents for the case history, but Davy was a very busy kiddo, so they decided to finish the assessment in the office. And this goes back to Standard 6 and virtual care. Parents report that they can't get him to sit and play with toys. The SLP decides on non-standardized testing based on his age, case history, and parent concerns. This is their rationale, which would be covered under Standard 10 assessment. Maybe the SLP needs to break up the assessment to multiple visits or different settings. The results of the assessment are that there are no concerns with Davy's understanding or expressive language. However, his speech is significantly disordered. Davy is easily dysregulated. He has inconsistent eye contact, but good gestures and facial expressions. The SLP sees some things common to neurodivergent children his age and suggests monitoring his social communication. The SLP will discuss the findings with the parents and the grandmother as requested by the parents. They'll discuss the goals and the treatment plan. While this is part of Standard 10, or assessment, it's also covered by Standard 13 on education and counseling. When creating a treatment plan, think about competency E, effectively collaborate with patients, other professionals, and relevant others to develop evidence-informed treatment recommendations that address the goals identified and that reflect the patient's strengths, needs, values, expectations, and constraints, as well as systemic or organizational constraints. For Davy, that means that in the preschool speech and language program, he may get a limited number of sessions or have to wait for services. In the PSL or private practice, consider family capacity. Can they bring him to you for regular therapy sessions? Is there a better approach?
So returning to Mr. Singh, while we appreciate that SLPs in acute care contend with very short admissions that often prioritize dysphagia assessments, if the language screening conducted by the SLP showed possible word finding difficulties, communicating that a comprehensive language assessment is indicated to accurately identify the nature of the issues, formulate conclusions, and make evidence-informed recommendations for intervention. This aligns with the competencies in both Standard 9 screening and 10 assessment, as you wouldn't make recommendations beyond the need for an assessment because not enough information has been collected to do anything else. Standard 11 requires that SLPs must make appropriate and timely recommendations and collaborate with other professionals when they do not have the required resources or competency for the patient intervention. Standard 12 requires that SLPs must implement treatment or consultation to support the patient in achieving their goals. It's important to note that this standard does not prioritize one approach over the other or propose that treatment is preferable to consultation. It will again depend on the specific patient and the service delivery model that you're working in. Standard 13, SLPs must educate and counsel patients and others on the nature of the communication and/or swallowing intervention needs and provide appropriate management recommendations. To reiterate, it's not the expectation that the SLP must progress through these standards in a strictly linear order. It's important to obtain consent before proceeding and to gather enough information from assessment before implementing, a treatment plan, but we expect that you will approach intervention in a way that makes the most sense for your individual patients.
The SLP recommends that Davy's parents talk with his physician about the concerns. The SLP may suggest they review the speech-language pathology report with the doctor, or maybe the SLP sends it to the doctor directly, of course, with appropriate consent. The SLP would suggest referrals to others, maybe occupational therapy, a developmental assessment, or audiology. Maybe there are limitations in the SLP's competency where they don't tend to practice with Davy's area of needs. In this hypothetical example, if Davy receives a diagnosis and the SLP is not competent with neurodivergent patients, they would therefore refer to others or identify alternate options. All of this falls under Standard 11, recommendations and collaboration. Competency E says respect when a patient does not consent to collaboration. Happily, Davy's parents consent. What treatment model is best for the family? Maybe Davy is great with his parents, but less so with grandma. Maybe the SLP will consult or provide treatment with the grandmother. The SLP could provide parent training or consultation, again, within scope. Consider how do the parents learn best? And this would be Standard 12 on treatment and consultation. Treatment will include virtual sessions with the parent or grandmother as they live in a remote area. This goes back to Standard 6 on virtual care. Treatment could include coaching with periodic sessions in person. back to Standard 7 in patient-centered care. Davy may be starting in JK by the time of the assessment or treatment. Collaboration and consultation with the school will be an important part of his treatment. And this is covered by Standard 12, treatment and consultation, and Standard 11 on collaboration. The SLP also recommends workshops in the community, like the library, or local agencies like the Child and Family Hub for families to attend, for Davy's family to attend specifically. And this is the partnership. Parents will have a role in therapy, collaboration with the family. This would all be education and counseling.
So the final two standards from the body of the document before the Dysphagia Appendix are Standard 14, speech-language pathologists must provide appropriate recommendations for discharge or further intervention and facilitate transitions when required. And Standard 15, SLPs must develop strategies that consider the patient's return to participation in home, work, school, and community. As Dana mentioned earlier, reintegration was a concept that had previously been reflected in only some of the standards, like the stuttering and acquired cognitive communication standards, but is applicable more broadly than those etiologies. So for our fourth poll, what should you do if your workplace wants to discharge a patient who still needs communication or swallowing intervention? Option A, advocate for your patient to have an extended admission and continued services. B, offer to continue providing the intervention privately. C, discuss other options for services, like providing a list of private practitioners in their area. D, inform your workplace that it is misconduct to discharge patients who still need intervention. Or E, get consent from the patient to make a referral to another SLP. And again, please choose all the options that you think are applicable. Okay, we still have some responses trickling in, but we do have a majority. Thanks to everybody who participated. It looks like the most common answers were A, C, and also a majority responded to E. So we agree that C and E are the responses that we would suggest. A isn't incorrect per se, but it might not always be realistic with the constraints of our healthcare system. For option D, it's important to note that paragraph 8 in the misconduct regulation around discontinuing services relates to the discontinuation of services that are needed, but does not apply when the services are restricted by agencies. So for more information on this, you can also refer to the e-forum that was held when the misconduct regulation was amended in July 2024.
In the preschool speech and language program, Davy still needs services, but will be discharged because of service limitations in the public system. Standard 14, and discharge. This could include further referrals, like to private services, if this hasn't already happened, although hopefully it would, and transition to school according to your system. Standards 11, recommendations and collaboration, and Standard 2 on consent. Standard 15 wouldn't apply to Davy as he is not yet reintegrating.
Before the end of Mr. Singh's admission, the SLP reviews supported communication strategies with both Mr. Singh and his daughter to support his participation in family conversation as he lives with his daughter and is an active grandparent. The SLP also provides patient-friendly information in writing and their contact information in case Mr. Singh or his daughter have any questions. This is an example of meeting the reintegration standard. What reintegration means for individual patients should be considered beyond returning to work or school, although those are important. The SLP also obtains consent from Mr. Singh to make a referral for outpatient speech and language services, including sharing necessary personal health information. This returns to overarching standard 2 consent and meets the competencies of standard 14 discharge. We appreciate that when a patient is discharged from the hospital is not the SLP's independent decision. Often patients will be discharged when they still need SLP intervention. Safe and ethical discharge in these instances means transferring care or making referrals to other individuals or organizations like outpatient rehab or outpatient instrumental assessment. So for the last section of the presentation, we'll briefly review the Dysphagia Appendix of the document, which is comprised of 3 distinct standards. The rationale for having an appendix for dysphagia specifically is that there are standards that need to be met in this area of practice that aren't comparable or transferable to other areas. This appendix largely reflects the previous standalone dysphagia standards with minor revisions to the content to address risk of harm for patients with dysphagia specifically. Standards 16 and 17 from the appendix are that SLPs must have the required competencies to conduct clinical and instrumental swallowing assessments respectively. Again, there is no equivalent to clinical or instrumental swallowing assessments in other areas of SLP practice. Because the Dysphagia Appendix was drafted with the previous standalone dysphagia standards as a template, the information in the Dysphagia FAQs and the 2022 e-forum is still relevant and available on CASLPO's website. In the next few slides, we'll go through the remainder of our scenario with Mr. Singh to conclude how the standards might be applied to a patient with dysphagia. So the results of the SLP's clinical swallowing assessment completed during his admission showed that Mr. Singh was coughing consistently immediately after drinking thin fluids. Independently taking small sips was not an effective strategy, and he had difficulty cutting his foods due to a right hemiparesis, but otherwise no difficulties were observed with solids. Standard 16 requires that a clinical swallowing assessment must enable the SLP to form clinical impressions and guide dysphagia management. To make appropriate recommendations, the overarching standards also apply, including involving the patient and taking patient context into consideration when making diet recommendations. For example, you might consider factors such as whether the patient is able to thicken fluids on their own or with support, cultural considerations, and food preferences. This reflects patient-centered care and respects patient autonomy. The SLP consults with the interdisciplinary team, including the physician and registered dietitian, which demonstrates standard 11 recommendations and collaboration. The SLP proposes a modified diet based on the results of the clinical swallowing assessment. This may be part of standard 12 treatment for patients with dysphagia. Balancing the risk of harm associated with aspirating with the risk of harm to quality of life and patient outcomes with overly restrictive diet recommendations is also an important aspect of managing risk of harm, which goes back to standard 4 risk management. So the SLP discusses the findings and recommendations with Mr. Singh and his daughter. As we've mentioned, practically the standards aren't intended to be followed in chronological order necessarily. In this instance, it may make more sense to discuss the proposed recommendations as part of education and counseling and obtain informed consent to implement the recommendations before proceeding with the steps described on the previous slide. Again, the overarching standards will apply throughout, including standard 2 consent and standard 3 documentation, as all these steps are documented. Prior to discharge from the hospital, the SLP and registered dietitian provide instructions and training on thickening fluids at home. This goes back to standard 14 and 15, discharge and reintegration, and standard 11, collaboration. The SLP reviews the recommendation for an outpatient video fluoroscopy and confirms that Mr. Singh is still in agreement and consents to the referral, reflecting both Standard 2 consent and Standard 5 resources. The last standard in the Dysphagia Appendix is Standard 18. SLPs must ensure that virtual dysphagia intervention is in the patient's best interest and that it is feasible, appropriate, and reliable. We have elaborated on the information in this standard to highlight the significant risk of harm associated with virtual dysphagia intervention. It would not be in the best interest of the public to prohibit virtual dysphagia intervention entirely, as we recognize there are circumstances where this is the only option for patients to receive care. However, SLPs need to be aware of and transparently communicate to their patients the limitations of this type of assessment and carefully make recommendations that take those limitations into account. So for the final poll, we will end the content for our presentation before we take questions. So the final poll is, how can virtual dysphagia assessments be conducted ethically? A, determine the risk of not providing intervention outweighs the risk of attempting virtual intervention. B, continue with virtual intervention once the patient consents to the risks. C, only offer virtual intervention as part of your service delivery model because it's convenient for patients. D, collaborate with those in the patient's environment to support the intervention. Or E, mitigate risks associated with forming clinical decisions based on virtual assessment findings. And again, you can choose all the options that you think apply here.
The votes are still coming in, but I'm going to close the poll.
Yes, thank you to everybody who responded. And the most common choices that people selected were A, B, and D. And
I think E too.
And E, thank you. Yes, and that is what we would agree. A, D, and E are ways to support ethical virtual dysphagia assessments. It's important to note that virtual dysphagia assessments are only appropriate when they are in the patient's best interest. So for example, if patients cannot readily access in-person services due to limited mobility or geographic location, not because it's convenient. The standards also require that SLPs assess the appropriateness of virtual intervention on an ongoing basis, considering the patient's unique needs, and continue to monitor whether it remains appropriate over time. SLPs must modify, limit, or discontinue a virtual assessment based on the patient's responses and develop an alternate dysphagia plan of care when required, which is why option B is not appropriate. It's not sufficient to only rely on patient consent to proceed without ongoing reevaluation of whether it remains in the patient's best interest.
Okay, so that takes us to the end of the formal part of the presentation, and we have about 10 minutes for more questions and answers. Which is wonderful. We'll just have to take a moment to look through the questions, unless there's any, Cassandra, that are popping out to you.
Yes, we did have one come in. My employer report templates in practice is that certain standardized tests are administered and included in reports. How can I navigate this with my employer given the SLP standards? I'm happy to take this one if it's okay with the two of you.
Sorry, that would be great.
So Please consider having a discussion with your employer regarding your clinical reasoning for using non-standardized testing methods. You may consider highlighting patient populations that may not realistically be able to complete a standardized test. For example, if the testing material is only available in English and the patient does not speak English, you may need to adapt the methods used to assess the patient's abilities. This is the type of conversation that might be helpful to have with your employer so that you can determine protocols within the clinic that can better address these types of populations and the services that you provide.
Okay, Cassandra has let us know that there have been a few questions about referring to private practice. I'm going to read the most recent one, which I think is representative of most of the questions. Please discuss further regarding making referrals for private services. Does one have to refer to specific practices or professionals, or simply recommend accessing further services privately? If specific, does one have to ensure that the professional or practice is accepting referrals at that time? Is there any truth to the option that we must provide 3 private referrals? No, there's no truth to that. So this is a good opportunity for us to clarify that. And is it always a conflict of interest to offer one's own services? So the key concept here is that of patient choice. So it's just that you are giving them options. There's not a minimum number of options that you need to give them. You could direct them to CASLPO's public register and help them search for private practitioners in their area. You can make recommendations for what you think would be appropriate for their specific needs. There's no minimum number. If you are offering your own private services, you can say, but this isn't the only option available to you, for example, and that would ensure that you are not finding yourself in a conflict of interest. So again, it's just about offering patients options for where they can receive the services that they need. Hopefully that clarifies things. And then on the point of whether you need to make sure that where you're referring is accepting referrals, CASLPO doesn't set that recommendation as a minimum regulatory standard. It may make sense to do that and to have the discussion with the patient so that you aren't pursuing dead ends for them to receive services.
I see a question on here that I could take. What if screenings are used to determine if the patient would be a good candidate for a treatment program? And I think it's important to think about terms like screening. The way that CASLPO defines it as it's laid out and defined in the standards is that a screening gets you one of 2 results, either pass, no concerns, or fail or refer, there are concerns, and further assessment is needed to set out the goals and figure out what needs to be worked on. But I have worked, I think, in research where it was considered a screening where you would do all these tests on the person to see if they would fit into this research criteria. And while it's called a screening, I guess it is because it's pass-fail in they would be good research candidates, but it was actually an assessment that was happening for the child in that case. And so determining if they'd be a good candidate for a treatment program, the use of the term screening might be different from the regulatory way to say it. Same thing with intervention. When CASLPO talks about intervention, it means screening, assessment, treatment and consultation, collaboration, like all of those things make up intervention. But I know that in the past I worked in places where intervention was another word for therapy or treatment. They were synonymous. So if we're saying intervention, and a question might come up of, how can you say these are intervention standards? That just means treatment. The way that CASLPO defines intervention is all of those things: assessment, treatment, et cetera, et cetera.
One that we got, is there an extreme case where it would be considered professional misconduct to just make do? For example, my school is undergoing renovations and there's never the chance to have a quiet room. Is it my professional responsibility to tell my employer something needs to change? If I continue to treat the S production when the child can't hear the sound, would that be misconduct?
So I'm happy to take this one. Caitlin, feel free to add if there's anything that you'd like to. the idea is that SLPs need to make a reasonable effort to have a quiet space. And so if we compared this to the previous acquired cognitive communication standards, there was a line in there that said SLPs should assess in a quiet room. So this is the idea again of the should, and the guidelines don't really help. So let's say that it was a must. That means that if you can't find a quiet room for an assessment, you are performing misconduct. So how many of you, I wish you could all raise your hands, have not been able to find a quiet private room in a hospital or a school to perform an assessment? So missing this must means that it's misconduct. And so that's what we took away, because that's not realistic to say that if you don't get a quiet room, it's misconduct. So instead, there's a competency in Standard 5 on resource requirements. And it basically says that SLPs have to organize the environment for optimal interaction and to maintain confidentiality and privacy. And so that competency would apply to this question as well on, if you can't get a quiet room, I don't know, let's say in a school, if there's renovations going on, you might not be able to hear if the student can make the sound, or the student can't hear you make the sound. So you can consider whether it's worth delaying therapy until the construction is finished, or talking to your employer or to the school or wherever it is to talk about the problem. Talk to, again, I always go back to kids, I apologize, but go to the kids, to the parents or the substitute decision maker and see what they want to do. Do they want to try to forge ahead with the sessions, even though you might not be providing accurate feedback because they can't actually hear if the child is making the sound correctly or not? And so for any of these decisions, it's really important to note your clinical rationale for making these decisions. So if the child's supposed to have sessions and you decide to put it on hold for a month with the consent and everybody's on board, note that in the record so that you or your employer or someone else doesn't come back to you later and say, what happened? Why is there this big break in treatment? I hope that helps.
So Dana, there's one more question here, and maybe I'll defer to you whether this is the last question before we end today. Somebody's asked, is there any guidelines on what is a reasonable time between assessments and treatment? And this would go back to the same principle for a reasonable time for documentation. We don't have guidelines or set that or define it because it will really depend. It will depend on your individual patients. It will depend on your workplace. It will depend on the presentation of your patient and the nature of the issues. So we don't set that. It will be up to your professional discretion, and your workplace's individual policies and procedures may have a bearing on that as well. But it would be the same.
And I can think of it to say that there's no right answer. Thinking about preschool speech and language programs, I know that some of them will have a very long wait for assessment, but then after the assessment, the child is seen almost right away for therapy, and then they're off to the races. So they have a long initial wait, but then no further wait once intervention starts. And other PSLs do it the other way, where there's a very short wait for the assessment and then a long wait for the treatment. And by doing it that way, they say, well, at least we can give the family strategies and we can get started, as opposed to waiting till getting on it all right away. And I don't think there's any right answer. I think that everyone is trying to do absolutely their best for patients, but there are wait lists that have to be managed. So sometimes the wait is at the beginning, sometimes it's at the middle, but do what makes sense for your system. I see a question on here, just to confirm, informal assessments are just as effective if clinically appropriate. Absolutely. Maybe the patient has not been exposed to English for enough time to do a formal assessment. There's no point in doing a formal test if they haven't had English exposure, because they won't do well, even though it's not something that would have been the same if we had a formal test in another language. That's just one example. I think there's an article in the Wave either this month or previously, but we tend to have often I'm sure that you can think of the issue, Caitlin. I can't at the moment. But the point of the assessment is to set goals. And so sometimes that can be using those books and those wonderful assessments. Sometimes we use assessments I used to call it, use them qualitatively as opposed to quantitatively. So I don't need a score, but I want to know what the goals are, what the problems are that the patient is having. So there's all sorts of great dynamic tests that might not be considered formal the way that they would have been defined to have in the past. But we want to think about what is the best way to get the information on what the patient needs and what the goals would be. Lynn, do you have anything to add?
No, I agree.
Okay, so that actually takes us, I just looked at the clock, to 1:15 and to the end of the time that we have for the presentation.
We wanted to thank everybody for attending today, and we hope that this was valuable for everybody.
Thank you so much. We will get back to those of you who have asked questions. And if you have other questions, just reach out to Practice Advice. Thanks so much, everybody.